Thank you, everybody, for being here today, and thank you for the invitation to come and talk. So today I'll talk to you a little bit about CML. I'm an assistant professor at Harvard Medical School, and I'm the clinical director of the Leukemia Service at Mass General, and my clinical and research focus is in myeloproliferative neoplasms and in chronic myeloid leukemia. I have these disclosures. So today's learning objectives. I will summarize the impact of patient monitoring, patient adherence, and therapy discontinuation on long-term patient care in regard to clinical pathway development. I'll also apply evidence base to discuss tyrosine kinase selection for CML patients and how to select tyrosine kinases based on disease phase, treatment history, genetic mutational profile, and patient comorbidities. I'll also talk about how to integrate clinical safety, efficacy, and cost effectiveness, and present some data on novel and emergent therapies in CML. So just in a little bit of background, CML is a leukemia that accounts for about 15 to 20% of of leukemia in adults. However, the prevalence is increasing as therapy has improved significantly in the last couple of decades, and it's projected that over 180,000 patients will live with CML in the year 2050 in the United States. The median age of diagnosis is in the 50s. Untreated, CML follows a triphasic course with chronic phase followed by accelerated phase followed by blast phase disease. The majority of patients are going to be diagnosed in chronic phase. And I think what's most remarkable about CML is that the prognosis with TKI therapy is similar to the general population. So a little bit of history. In 1951, William Damashek, who is also the father of chronic myeloproliferative neoplasms, described an entity called chronic granulocytic leukemia. Now, obviously, we call it chronic myeloid leukemia. In 1959, two investigators in Philadelphia at UPenn and Fox Chase identified an abnormality in the chromosomes of patients with CML. And this was the first time that a cytogenetic abnormality was consistently identified with neoplasia. We now call that abnormality the Philadelphia chromosome, and we know that that happens from a translocation of chromosome 9 and 22, leading to a fusion protein called the BCR-ABL. CML is a unique disease because BCR-ABL is the sole genetic mutation that occurs in these patients in the vast majority of times. There really is no CML without BCR-ABL. So if you suspect that somebody has CML and you don't identify a BCR-ABL, then it's likely another myeloproliferative neoplasm. In some instances, there's unusual BCR-ABL proteins, but for the most part, you don't have CML without BCR-ABL. Although whenever I talk about BCR-ABL in clinic, Siri turns on. Which is good. All right. So although mutations in the ABL1 kinase domain can occur, they really rarely occur at presentation. So it's not necessary to check for ABL1 kinase mutations in a patient that you're meeting for the first time if they're presenting in chronic phase. So CML is really a unique disease. We have excellent therapies. And 2001, when Gleevec was approved, was really a watershed moment in oncology. CML used to be the most common indication for bone marrow transplantation, and now it's one of the least common indications for bone marrow transplantation. And it became a disease that can be treated with medication, with just one pill. In 2019, in addition to having imatinib or Gleevec, we have 3 other drugs that can be used in first line, including dasatinib, nilotinib, and bosutinib. And we also have ponatinib for more advanced disease. So although we're very fortunate in that we have excellent medications to treat this disease, there are some remaining challenges. One includes really living with a chronic illness and dealing with the side effects of these medications. So although they're just pills, they still can be very difficult to take. The other is resistance, and last is cost, which is not an insignificant part of treating this disease. So a few things that I'll talk about throughout our talk today. As I mentioned, we have 4 drugs that we can use for upfront therapy, but it's not always straightforward to know which drug to select in the upfront setting. It's also important to know, and I'll discuss this a lot, how to monitor a patient to ensure success. And then we also need to know when to recognize that another TKI is needed. And lastly, we'll talk about who can safely discontinue their TKI. So first, I'll start with a case of a woman I've been taking care of for the last couple of years. She's a lovely 68-year-old woman that has multiple medical conditions, including diabetes, high blood pressure, coronary artery disease, chronic kidney disease, and she first presented with retinal hemorrhages. Her white count was 72,000. She was slightly anemic, and her platelets were preserved. So what is the right drug for her? And her spleen was not palpable on exam. So she, before talking about which drug to select, I just wanted to talk about the efficacy of these drugs, mostly to point out, I'm not going to go through each individual column, but there is no difference in overall survival with the different TKIs. So undoubtedly, nilotinib and dasatinib will get people into remission faster than imatinib. However, that initial deep response or that initial speed in response has not yet translated to a difference in overall survival. So the rates of cytogenetic remission may be a little bit lower for an imatinib compared to nilotinib and dasatinib, but the rates of survival at 5 years are the same, or long-term are the same. I guess one thing to point out is that perhaps with imatinib there's a slightly increased rate of transformation to accelerated or blast phase disease compared to the other TKIs, but again, that has the small numbers, it's an infrequent event. And with bosutinib, since it's the newest drug on the armamentarium, we don't have such long-term data. And then I just wanted to point out that although these drugs are incredibly efficacious in first line, there really is a bit of a change in their efficacy in second line, especially if the reason why you're selecting a second drug is due to resistance and not to intolerance. And so just to point out, second line progression-free survival with dasatinib or nilotinib is in the order of 40 to 50%, which is really quite different than in first line. So how do we pick our first tyrosine kinase inhibitor? So the right answer, and what the NCCN Guidelines say, is that you can use any of these drugs. What I like to do is just think about the patient, think about their medical comorbidities, and think about what your endpoints are for the patient. And so if you have patients that have pulmonary disease or patients that have congestive heart failure, and they often get admitted with pleural effusions or fluid overload, dasatinib is probably not the right drug for them, or not the drug that I would pick as first line. Patients that have chronic GI issues or have abnormal liver function tests at baseline, bosutinib is probably not the first drug that I would select. Patients that have cardiovascular comorbidities, especially patients with peripheral vascular disease or coronary artery disease, patients with arrhythmias, I wouldn't select nilotinib. Patients that have had prior also cardiovascular disease or history of any clotting events, I wouldn't select ponatinib, not that you would select ponatinib in first line anyway. And then patients that have lots of comorbid conditions, that are elderly and have cardiovascular comorbidity especially, I generally go to imatinib first. And so anyway, those are some of the considerations. So in addition to selecting the drug based on the patient and based on the patient's comorbidities, oftentimes, unfortunately, we also have to make decisions based on what the patient is able to get covered by their insurance. And so we sort of have to balance efficacy and cost. In general, we're pretty fortunate in CML that all of these drugs are really effective. And so when you have to pick one drug because the insurance will be more likely to cover one drug versus another, or there's a better patient assistance program for one patient based on their insurance than another, at least you can feel confident that you're not compromising efficacy, and I think that's important. Now, in 2016, generic imatinib was introduced. And in the United States, the cost of generic imatinib has not yet come down significantly compared to brand name imatinib. In other parts of the world, the cost of generic imatinib is significantly lower than the cost of brand name imatinib, and that's significantly lower than the second-generation drugs. But that hasn't yet happened here. Obviously, there's a potential benefit to generic imatinib in that it'll be significantly less costly. The cost of these drugs is significant and has not come down since the approval of these drugs, of imatinib in particular in 2001. One potential downside is, there's different formulations. Just anecdotally, my experience with some patients on generic imatinib is that they don't always tolerate it the same way as brand name. And so I think it remains to be seen how the introduction of generic imatinib will really impact the way that we take care of our patients with CML. There have been some cost-effectiveness studies trying to see if it's beneficial to start with generic imatinib in terms of cost. And they're trying to weigh that against the potential of more patients discontinuing tyrosine kinase inhibitors when they start the second-generation drugs. But I think that those analyses really are incomplete yet because we don't yet know what the price of the generic imatinib will really be. But I think that that'll be interesting, and I think that that'll potentially really change the way that we treat our patients. And I think we need to have more studies to help inform if that is the right approach for every patient. And so potentially in the future I can envision that we would start with generic imatinib, and then if our patients don't meet their landmarks of treatment, then we can switch them to the second-generation drugs. And I would say that for patients that have high-risk features of disease at diagnosis, that's unlikely to be the right strategy because those patients should really start with a second-generation drug. So anyway, things to look forward to in the future. So case continued. My patient was started on imatinib based on what I mentioned before. She had a lot of comorbid conditions. Unfortunately, at 1 year, her PCR on the international scale was 3.5%. And we want the PCR at 1 year to be less than 1%. So she hasn't achieved a major molecular remission being defined as a PCR of less than 1%, less than 0.1%. So at this point, and this is a question where you don't answer on your phone, you can just raise your hands if you want to volunteer. So do you perform a bone marrow biopsy to see if she's in a cytogenetic remission? Do you obtain ABL1 kinase mutational testing? Do you stay on the same therapy? Or do you do A and B? And if I don't have any volunteers, I'll let you know what happened in the next couple of slides. Go ahead. C? Yeah, sounds good. Anybody else? So she actually stayed on imatinib, but I don't think it's wrong to be worried at that stage of disease. I would say that just imatinib usually takes a little bit longer to get into a deep remission, but this is definitely a patient that I was worried about. So in order to know, when to switch therapy and who to worry about, we need to know how to define success. So the NCCN Guidelines have very clearly delineated this, and I refer to them often myself. And so at different time points, we want to be at different places. So really at 3 months, your patient should be in a complete hematologic remission, and that PCR should be close to 10% or less. Patients that don't reach that, you should be worried about. At 6 months, again, they have to be less than 10% on their PCR. At 12 months, they should be less than 1%. And then beyond 12 months, ideally, they should be in an MMR or just remain less than 1%. You always worry about patients that have reached these milestones and then lost those milestones, so if they've lost their response. And in addition to meeting the milestones of therapy, they also need to be tolerating therapy and affording therapy, which sounds obvious, but doesn't happen all the time. So what are some reasons for failure? It's interesting, I'm used to being an oncologist. My patients are usually very motivated and really, adhere to all of the therapies that are prescribed, even though sometimes that's very challenging. But the further away the patient moves from their initial diagnosis, the more they lose the fear of what this disease really is, and really adherence is a problem. This is a drug that patients have to take every single day of their lives. And so non-adherence is really an issue, and it's really the first thing that should be looked at. So the other thing that's important to take into account is drug interactions. And so although theoretically drug interactions could make the TKI not as effective, that hasn't really been shown in the literature. But what I think actually can happen is that drug-drug interactions can make the toxicity of the TKI worse and then increase the likelihood of the patient not being adherent with medication. Another real reason for lack of success is cost. Also intolerance. These drugs, for some patients, they're incredibly well tolerated. They don't even feel that they're taking a medication, but for some patients, they really have debilitating side effects. And then, of course, we deal with resistance and with relapse. So my patient did not want to have a bone marrow biopsy. Mutational testing was normal, and she remained on imatinib. She wanted to give it a few more months to see what it would do. Unfortunately, at 3 months, her PCR was unchanged. So she was started on dasatinib, 100 milligrams daily. At 3 months, her PCR was 0.7%. So how do we navigate TKI resistance, and how do we think about it? Like I mentioned before, we have to ensure that there are no drug-drug interactions, that patients are actually filling their prescription and can afford therapy. And then how do we define TKI resistance? So primary resistance is failure to meet the landmarks of therapy at specific time points. Failure to reach MMR, or major molecular remission, is not infrequent. So it occurs in up to 25 to 40% of imatinib-treated patients and bosutinib-treated patients, and occurs less frequently, but also in patients with dasatinib and nilotinib. Relapse, so also you can think about it as secondary resistance, is loss of therapeutic effect and disease progression while on a TKI that was previously effective. And the NCCN defines it as any sign of loss of response, defined as either hematologic or cytogenetic relapse. So if you have a patient that was previously very well controlled and they have a 1 log increase in their BCR-ABL transcript with a loss of MMR, so if they're still in MMR, you don't worry, but if they've lost their MMR, that's considered relapse. So when do we check for an ABL1 kinase mutation? So if you have a patient that's in chronic phase that you just met, if they're achieving their milestones, you don't have to check mutation. But if they haven't met their milestones, if they've lost response, if their disease is progressing, then that's a good time to check mutational analysis and to select a tyrosine kinase inhibitor based on those results. For new diagnosis patients in general, there's no reason to do mutational testing, and with the exception of patients that present with accelerated or blast phase disease, which thankfully is rare. So here's a chart, and I have to say that I treat a lot of CML, but I do not have this memorized except for maybe a few. So the chart is here. It's also in the NCCN Guidelines. I refer to it all the time. But anyway, it's just helpful to know which tyrosine kinase to select. So then really a more common thing than having mutations in ABL1 kinase is intolerance. And this is why it's so important, I think, to understand the side effect profile of each of the drugs to help, not just with selecting the drugs up front, but then really to help patients stay on therapy. And I would say, CML patients appear like they're doing well. Their blood counts can be pretty normal. And then they look normal, but these patients can really suffer from a lot of chronic toxicities. And I would say that in the first 3 months of therapy, those toxicities are much, much worse, and they tend to get better over time. So in the first 3 months, I really have the patients come see me in clinic pretty frequently, not only to check blood counts and make sure that they're tolerating therapy from that perspective, but to really to help navigate the side effects that tend to be, like I said, much worse at the beginning. So with imatinib, we have fluid retention, fatigue, rash, myalgias, lots of GI side effects. Dasatinib obviously can cause a lot of those similar side effects, but specifically can cause pleural effusions and rarely can cause pulmonary artery hypertension. Nilotinib can lead to vascular events, peripheral vascular disease, worsening in hyperglycemia, QTc prolongation, and rash. Bosutinib, particularly at initiation of therapy, it can cause a lot of diarrhea, and it's really important to educate patients about the fact that they can have a lot of diarrhea at the beginning and to manage that very proactively, because otherwise most patients will not be able to remain on therapy. But once they've overcome those few first months of therapy, I find that it's a pretty well-tolerated drug. And then ponatinib, as you all may know, it's been associated with a lot of thrombotic events, vascular occlusion, CHF, hepatotoxicity, and rash. And I would say that in pancreatitis, I would say that all of these drugs together, one of the things that they have in common is that they really cause a lot of fatigue. That's probably the most debilitating chronic low-grade side effect that most of my patients have with these drugs. So my patient did well, but unfortunately she called me one day sounding very, very short of breath. She got admitted to the hospital, and this was her chest x-ray. And this is a little bit small, unfortunately, but the Sprycel package insert has a really nice algorithm for monitoring or managing pleural effusions. But just to say, the first thing to do is grade the pleural effusion. If it's grade 1, 2, not very severe, you interrupt the drug and you wait for it to resolve. Once it resolves, if it was really not that severe, you can start at the same dose. If it happens again, then you can start at a lower dose. If you have a patient that has grade 3, 4 pleural effusion, you stop. If the pleural effusion doesn't resolve within a week of treatment, you can consider obviously diuresis or short course of corticosteroids. And then you can restart the drug at a lower dose. So I usually do 70 milligrams, but you can do 50 milligrams as well. And obviously if that recurs, then that patient can't be on dasatinib anymore. And although pleural effusions are quite common with dasatinib, the vast majority of patients that get a pleural effusion on dasatinib are able to remain on the drug long term. So unfortunately, she ended up getting 2 pretty significant pleural effusions, so we had to, so what do we do now? In this case, it's really not selecting in second line, it's kind of selecting in third line, but in general, the same paradigm applies. So if a person is on imatinib and they have resistance to imatinib, then you have the other 3 drugs to pick from. In the past, and you may find some literature that suggests increasing the dose of imatinib from 400 to 800, but truthfully, that's not very well tolerated. And nowadays, when we have so many other drugs to select, that wouldn't be my first approach, unless for some reason, the patient really can't take any of the other drugs, or you don't have access to the other drugs. If the person is on a second-generation tyrosine kinase inhibitor, then I would select another second-generation tyrosine kinase inhibitor. I wouldn't go to imatinib based on mutational profile, or if there's no mutation identified, then I would just choose the other second-generation drug. And then the setting of the T315I mutation is really different than all of the other mutations. So if a patient has a T315I mutation, the only drug available for that patient is ponatinib. And in the right clinical setting, this is a time where I think the conversation should start about a bone marrow transplant. So ponatinib is an incredibly efficacious drug, but I don't think we know yet if patients can really remain on ponatinib lifelong. And so I think it's at least worth discussing transplant with these patients. When it comes to intolerance, if the reason to switch from one drug to another is intolerance, then really any TKI with a different side effect profile is an acceptable choice. So now switching gears, and something that's kind of exciting and that I think was surprising to a lot of people is TKI discontinuation. So now that we've been using the tyrosine kinase inhibitors for many years, we know there's some patients that really go into excellent remissions. And there's a mounting body of evidence that has led to the opinion of the NCCN Guidelines that it is now safe to discontinue TKIs in well-selected patients. And I think that's really the most important thing to know, that we know that TKI discontinuation is safe. So you can stop the drug, and then once you restart the drug, patients will go back into the great remissions that they had before. There's no reason to change from one TKI to another. And I think that's really the most important thing to keep in mind. But discontinuing a TKI is not that easy either. And that's because, some of these patients maybe are patients that we're now seeing twice a year because they're in such good remissions. Now they really have to get blood work done to check for their BCR-ABL transcript levels. In the first year, really every month, and then it's every 2 months. So it's fairly frequent visits because obviously you don't want to take a patient that's doing wonderfully and then have them really relapse with, accelerated or blast phase disease. That would be a terrible outcome. And so I think it's important to have patients that are reliable, that are willing to do that. And I've definitely had patients that are doing so well on their drug, on their TKI, that they prefer to just stay on what they're on and not do the monthly visits. So what ensures success? So we know that 50 to 60% of patients will relapse, and really many of those relapse right away in the first couple of months, even if they had undetectable disease before. We know that the longer the patient has been in remission and the deeper that duration of remission, the higher the likelihood of success. Patients that had low risk SOCAL score at diagnosis also have a higher likelihood of success. And so the NCCN guidelines are here. Obviously, I'm not going to go through all of that, but just to say that patients are candidate for discontinuation if they've been on a tyrosine kinase inhibitor for at least 3 years in an MR 4.0, which is 0.01 or greater, for the last 2 years. Patients can't have a history of accelerated or blast phase disease. And like I mentioned before, patients really need to be willing to come and get their transcript levels checked fairly frequently. So kind of in summary, on a TKI for 3 years, MR4 for at least 2 years, and they really require frequent follow-up. So just a few things that I've sort of mentioned throughout the talk, but I just wanted to spend a minute emphasizing again. One of the nice things about taking care of CML patients is that you really get to know them and take care of them over many, many years. And as the CML doctor for these patients, knowing the toxicity, not just for selection, but just kind of following them throughout their course is really important because these toxicities, even if they didn't appear at the beginning, can appear at any time during treatment. And so for dasatinib, kind of the longer you're on it, the higher the likelihood is that you're going to have a pleural effusion. And so recognizing that obviously is important. Recognizing that there's some rare complications of dasatinib, such as pulmonary artery hypertension, is important. Patients may be on nilotinib for a long time and then develop coronary artery disease or something like that. So even though at diagnosis they may have seemed like appropriate candidates for nilotinib, that may change throughout their therapy. I think that the oncologist really plays a critical role in helping the CML patient in navigating their care with other specialties. So it's not infrequent, that these patients, because they live with this disease for so long, are likely to encounter other medical problems. They'll be hospitalized. They may need to have surgery, et cetera. And so I think that educating the other specialties about what the care for these patients means, and that these patients are not, severely immunocompromised and they can undergo usual routine surgery, all of these things are really important. So you're really, I think that that's a really important role of the oncologist for CML patients in particular. So just switching gears a little bit to kind of what to look forward to in the future. So as folks were doing studies looking into TKI discontinuation, one theme they came up in the imatinib studies was that patients that had been treated with interferon and then with imatinib seemed to have more success with TKI discontinuation. And I think that led to several studies trying to combine TKIs with interferon. So imatinib with the old interferons really wasn't very well tolerated, but now we have newer interferons, such as pegylated interferon or Pegasus, and another interferon called ropeg interferon that we don't have available in the United States. And there's some ongoing studies trying to combine those interferons at low dose with the different tyrosine kinase inhibitors to see if patients get into deeper remissions, and then ultimately if those patients can discontinue therapy more successfully. There's a few other kind of newer agents that are on the horizon, perhaps. So I think one of the most exciting is ABL001. So this is this inhibits the ABL1 kinase in a different mechanism, and so it can potentially overcome a lot of TKI resistance, and that's going through clinical trials in several different settings. There's rodatinib, which is another TKI, which has been studied outside of the United States and really does seem to have really excellent efficacy and superior to imatinib in rates of cytogenetic and molecular remission, but it has not really been studied in the U.S. And then there's been some studies combining nivolumab, a checkpoint inhibitor, in combination with dasatinib in patients that have failed initial therapy. And so that's kind of an interesting strategy. We know from the transplant days that patients with CML are really susceptible to the immune effect of transplants. So it made sense to think about using checkpoint inhibitors. I think that that's been a study that's been difficult to accrue to simply because of there's low numbers of patients that really need that, and the TKIs are usually pretty well tolerated, and the checkpoint inhibitors can be potentially more toxic. So we'll see what the results of those studies are to see if that's a compelling treatment approach. So remaining challenges in CML, a few things that I've mentioned and I'll mention again. So the majority of patients with CML really do very, very well. But like I've mentioned, living with chronic TKI-related side effects can really be very challenging for some patients. Most patients, however, will not, unfortunately, remain off of TKIs for a long time. So although TKI discontinuation is definitely a possibility and something that I talk to my patients, it's important to keep in mind that the vast majority of patients will have to be on their TKI for the rest of their lives. They may have some treatment interruptions if they meet criteria for discontinuation, but not everybody. So I think some things that I'd like to see improve in my lifetime would be, how to manage life on a tyrosine kinase inhibitor better. There's only so much we can do with supportive care. I think probably the most challenging side effect to manage is fatigue. We have, medications to give people with GI upset, with volume overload, with GI side effects, et cetera, but fatigue can really be difficult. And then how do we select patients, and how do we increase the possibility of TKI discontinuation? So obviously if we can treat these patients, even if it's with somewhat toxic therapy initially, but then really increase our likelihood of TKI discontinuation, I think that would be really exciting for our patients. Thank you so much. I'm happy to take questions.